KwaZulu-Natal, and also the principal investigator for the QuEST Center in South Africa. We are going to tell you more about QuEST this afternoon as we introduce you to the program of work that we are currently doing. I want to start by taking this opportunity to express my gratitude for all of you who have joined this meeting this afternoon. Those of you who are online, you're also most welcome as participants. Those of you who are in the room also, thank you very much for agreeing to join us and making yourself available. We do recognize that it is a difficult time in the health sector at the moment, given the instability because of the protests that are currently ongoing across the country. And we also understand that many of our health leaders are constrained in terms of time because of these engagements that they need to be part of. I do hope that some of the conversations that we are going to have this afternoon and discussions we're going to have can also go in a small way towards solving some of the problems we have in the country. So just by way of background, I just want to let you know a little bit about why we got to this point. In 2019, towards the end of 2019, we were invited to a meeting in Boston in the US, where we were meeting with colleagues from various countries across the globe, really. And the main person who was inviting us was Professor Margaret Crook, who's here with us today from Harvard T.H. Chan School of Public Health. And she was inviting us because they had completed an extensive body of work as part of what they called a Lancet Global Health Commission for high quality health systems. And South Africa, it so happens that it was also part of that investigation. It was an extensive global investigation whereby our former Director General of Health at National, Dr. Precious Matsoso, was part of that commission. And if you have seen the report from 2017, you'll see that her name is also reflected on that report. And essentially what they were trying to figure out is how do we transition, how do we move forward when it comes to health systems? We know health systems are complex, and yet all our health outcomes depends on health systems that actually work, that can improve outcomes, and that can actually have the necessary impact in people's lives. And after that body of extensive work, they concluded that two things needed to happen. They came up with a framework that essentially gave us a roadmap towards how we may be able to achieve high quality health systems. All countries have health systems in one form or another, but really the challenge here is how do we make sure that our health systems are of high quality and they are able to offer high quality service delivery. They came up with a framework that you will hear about today that essentially gives us a roadmap towards high quality health systems. But in addition to that, they said that two things needed to happen. One is that we need to improve health systems. And so improvement became a major part of the intervention that is needed in order to make sure that we can raise the quality and impact of our health systems. But before you get to improvement, you need to measure. So measurement became another important part of what we need to do. And now, if we are going to do measurement, we need to know what is it that we are measuring and how we are measuring it. So essentially, when we met in Boston at the end of 2019, it was for this reason, to try to think about how do we move forward together as partners from different countries. And out of that, that is how this program of work that we call QuEST was formed, that you will hear about. Now, it so happens that it was formed just before COVID. And so immediately after we set it up, we were, of course, derailed by a huge body of work around COVID, in as much as we were still pushing some aspects of it. But really, we pivoted as a group to try and deal with issues related to COVID, which was really timely as well. And, it was an opportunity. But for us here in South Africa, we have also made quite a bit of progress in terms of organizing ourselves in taking this work forward, even though it's a discussion that's been ongoing for a while. So I am shortly going to basically give you an opportunity to hear more about this work. But before I do that, I want to take this opportunity to welcome all of you once again. We've got a number of people that have agreed to be here to witness this moment, a number of people that are in the room, and a number of people that are online as well. I do want to specifically welcome Dr. Bibi Bengubaloy, who is in the room, and she is a commissioner in the Premier's 7-member planning commission for the province of KwaZulu-Natal. I also want to welcome our College Dean of Research, Professor Anil Chutagun, who is also in the room. And I know that there's a few people who are online that I would also like to warmly welcome, including Dr. Anban Pillay. Dr. Anban Pillay from National has been having some conversations with me in the past few months, essentially saying that there is a missed opportunity, in the sense that a lot of the work that needs to be done in health requires a strong partnership between the university and the Ministry of Health, the Department of Health. And he was basically saying to me that we need to think about how to strengthen that partnership. There is no way we will be able to, and we saw this during COVID, we will be able to innovate in the Ministry of Health or in the Department of Health or in the health system if we are not involving researchers, academics, and if we are not drawing on the resources that are sitting in universities, in research centers, in institutes, if we're not drawing on the different partnerships that universities are able to formulate in order to advance the work of innovating in health. And also, the point that he was making was that health can really benefit from a closer relationship between the officials in the department and academics who are interested in health systems and health services. There is also priorities that the department has and that they would like researchers to tackle for the ministry. A lot of the times we come up with our own research questions and we take those research questions forward. Sometimes they end in publications. Their relevance to the health system and impact in the health system at times may be limited. So he's basically saying, let's try and channel our efforts and make sure that we concentrate them on the things that matter most within the department. We also have, hopefully online, our HOD of health in KwaZulu-Natal, Dr. Sandile Chabalala. we've been working with and this is also a story that I explained to Dr. Pile, to say that, as the University of KwaZulu-Natal, we've been working closely with health in KwaZulu-Natal for some years now, trying to build and foster a closer working relationship in terms of just thinking together, in terms of coming up with priorities, in terms of strengthening health systems. And we have come a long way in that effort, but what has become clear is that we really need tools that can help us to move forward. And I'm hoping that part of the discussion, what we're going to discuss today, will also offer tools that can help us to move forward. Those of you who are members of the Transformation Committee for PHC in KwaZulu-Natal will know exactly what I'm talking about. So I want to also welcome all of you for joining us. We are also going to, besides the launch, we are going to be having a policy workshop over the next 2 days that we are very much excited about, that our partners in the Ministry of Health, both at province, but also at national, will be joining us in order to discuss some of these key issues and questions. So I think with those few words of welcome, I do want to welcome you once again. I've been notified also that for the Premier's office, Mr. Sbu Ngubane has been sent to also represent the Premier's office. And I believe that Mr. Ngubane is the DDG. And I also want to welcome you warmly, sir, and all the other guests that are here that we are very happy to see. You are most welcome, and we're looking forward to a fruitful discussion this afternoon. Let me take this opportunity then to invite Professor Anil Chitugun to say a few words of welcome. This is an event that is hosted primarily by the University of KwaZulu-Natal. The work is housed in the College of Health Sciences. We are working in partnership with the THN School of Public Health at Harvard, but I do want to invite you, sir, to say a few words. Thank you very much.
Good afternoon, distinguished guests, colleagues, and friends. And thank you, Musa, for allowing me to say a few words at this very august occasion. As you may know, we are a new university, but we have a rich history. And the fact is that we have a medical school, which was initially established during the apartheid regime to allow Black students to enroll to become doctors. And is that university, the University of Natal Medical School, that merged with another traditional apartheid institution called the University of Durban-Westville to form the University of KwaZulu-Natal. I say this with pride because we are rooted firmly and we deliver on our promises. And I just want to say to the team from Boston, it says University of Choice, and you made a very wise choice to choose us. Having said that, I just want to tell you that when the COVID pandemic came around, and I'm speaking about the innovative spirit of our students and our staff. So during the COVID pandemic, we had several staff members that were on the ministerial advisory panel, and our TV star and movie star sitting right here, who was speaking a few minutes before me, who played a very active role in that. Having said that, we are one of the universities in South Africa that accepts disadvantaged students from rural communities. We have the highest enrollment of these students at our university. And during the lockdown, they couldn't get back home in time, so they were forced to stay in residence. And that meant that we had to do active testing, et cetera, on them. But as you know, the PCR tests, the PPE, et cetera, was horrendously expensive. So we innovated methodology where we created in-house tests and kept our students safe in the residences without there being an outbreak of COVID in those residences. So the point is that to the colleagues that are here from overseas, you have a team of dedicated people that will be working with you UKZN is recognized for its innovation in HIV and TB. We have robust financial administration systems. So all of that makes for a great partnership. And I'm looking forward to some great innovations and from this venture. And hopefully, as Moshe said, that we do have some strife in our health systems at the moment. And from what you produced during this research, we're hoping that things will be better and our people will have better lives thereafter. Thank you very much.
Yeah, colleagues, thank you very much. So that is Professor Anil. Thank you for your kind words and your warm words and reminding us of the stature of our university and its commitment to innovation and societal impact. I want, without wasting time, to do a few things. I know that there is protocol to observe, but I want you to allow me to break protocol a bit. We are going to have inputs from our colleagues in the state. We're going to have inputs later from the National Department of Health, from the Provincial Department of Health, and also from the Premier's office. But I want to take this opportunity to essentially introduce QuEST with a brief talk that's going to come from our research partner, Professor Margaret Crook, who's going to essentially give you an overview of what this is about. And I hope that can frame the discussion so that when we also get inputs from our government partners, then they have a fuller understanding of what it is that we are talking about. I'm fully aware that not everyone understands fully what this QuEST thing is about. And I want to take this opportunity to invite Dr. Margaret Crook, who has come all the way from Boston to come and join us for the whole week of research discussions and debates. And Margaret has a presentation that she's going to share with you. But also, I'm hoping that she can also give you a little bit of flavor around some of the original work that led to this. Margaret, over to you.
Good afternoon, and Sani Bonani. I am so delighted to be with you today in beautiful Durban. We chose this city very strategically for its incredible weather and also for the university of choice. The partners that we have already experienced and had over the last couple of years of COVID at the University of KwaZulu-Natal, led by Professor Moshe Bella, couldn't have been more important to the development of QuEST, and also a critical thought partner for this whole area, for this whole network. So we're very happy to finally, after being laid low by COVID from our ability to travel, we're happy to be in person together with the team today. So thank you again for welcoming us. Let me just take a few minutes then to share with you some of the motivation and some of the work and research that has come before QuEST, that has given rise to QuEST, because we would love to get your feedback and we would love to get your reaction. And in particular, how the issues that we explored at the global level with many partners across many countries, how those issues resonate with you today in South Africa and in the province of KwaZulu-Natal. So we're really eager for that input. So first of all, hang on, I seem to be, let's see if I can do it this way. Oh, okay, now it's, okay, perfect. Okay, great. Professor Mosa mentioned that the QuEST idea comes from a big commission, Lancet Global Health Commission on High Quality Health Systems. And he also mentioned that a critical component of that commission, critical contributor to the commission, was one of your very own colleagues here in South Africa. And in fact, it was information and data from South Africa that inspired much of the commission's work. You may not recall, Mosa, that actually our second commission meeting of the Lancet Commission happened in South Africa. And it was here that we developed some of the recommendations that now are situated in this report, and that I think have at least stirred up trouble, stirred up good ideas across many countries. So you really are an owner of these ideas from the very beginning. What did we do in the Lancet Global Health Commission? We began by defining what is a high quality health system. What do we mean by that? How can we even think about that across so many different economic contexts? Does it mean the same thing in one country as in another? Well, what we decided as a commission is that actually in every country, a high quality health system has three primary tasks. And those are to consistently deliver care that improves or maintains health. Here, I'm really looking to the colleagues, particularly in the Department of Health. I'm curious what you think about the goals of your health system. Do they meet these goals? Are we able to consistently deliver care to improve or maintain health? Are we generating a sense of value and trust in the population? Are we bringing the people along? And lastly, are we able to respond when a shock hits? When the need to change occurs, are we able to adapt and respond? So those are three characteristics of every high quality health system in any country. We then developed this framework to think about the health system. And I want to just take your attention to the foundations for a moment. Every health system is built on foundations, like every house. And those foundations include issues like health workers and clinics, what we call platforms for care. They include tools, equipment, medicines, and so on. But they also include two kind of overlooked areas, which are governance. How is governance organized? And also, what does the population need and want from the health system? Every system is based on these foundations. And in order to make progress, we need to understand how these are functioning. That's what we need to do as researchers, as technical experts, as policymakers. But what I want to tell you today is that people don't care about that stuff on the bottom. What people want is the system to work for them when they get sick, when they have a need. And what people care about are the areas on top of this framework. They would like to have a competent nurse when they come to clinic. They would like to have a clerk who treats them kindly and does not make them wait for 3, 4, 6 hours for this visit. They would like a health system that remembers their HIV test result. They don't have to get retested and retested multiple times. Competent care, competent systems, good user experience. That's what people care about. And they also care, and we all care about the impacts of quality health systems. And those include better health. They include confidence in the health system. And they, of course, include financial protection, because people care about their health, but they cannot put all of their income toward health, right? They have other priorities as well. So let's talk about health. Are health systems achieving good health? What we found in one of the analyses undertaken by the Commission is that when you look at comparison of mortality in high quality health systems today with systems in low and middle income countries, what we see is an excess mortality of 8.6 million people a year. Furthermore, by applying some assumptions, and this isn't perfect data, I will be the first to admit, right? These are estimates at best. But what we can say is that unlike 20, 30, 40 years ago, today, most people who are dying are not dying because they refuse to seek healthcare. They are dying despite having sought healthcare. And so what we are saying is that poor quality is responsible for 5 million of these deaths, and lack of access is responsible for 3.6 million. So this is just a very, I think, important number for us to keep in mind in clarifying where the challenges lie. We have an access problem. I know that there are parts of your own country where there are still access problems. And certainly in certain kinds of weather, for example, there continue to be access problems. But what I want to put to us today is that first and foremost, most health systems are now facing a quality problem. In South Africa, we have data for South Africa that estimates that almost 100,000 deaths, this is in 2018, were occurring that could have been treated by the health system. These are treatable deaths, treatable conditions. preventable deaths. And what we further estimated for South Africa is that about 53% of your deaths were due to low quality, and the remainder to poor access. So why are people dying despite coming to clinic? I think that's the question we all need to be asking. Why are people dying from treatable conditions despite coming to clinic? Well, we have some glimpses of what's going on, again, from evidence that was collected in many countries. Each of the dots on this slide, which I appreciate, it's hard to see perhaps, but each dot actually represents a whole country. Each dot tells us about what healthcare workers did in a visit with a sick child or with a pregnant woman, from the perspective of a nurse standing in the corner of the room and writing down what happened. So she's doing a checklist of things that occurred. And what we see from those lists and from this research is that actually only about 40 or maybe 50% of the recommended clinical tasks were done in healthcare visits, even for very common conditions, ones that this country and many countries have been dealing with for 50 years. We're seeing underperformance of basic tasks. You might say, well, what tasks are they missing? Well, here's one. Only about 30 to 40% of mothers walk out of a visit with their sick child knowing anything about the diagnosis. So imagine that. You come a long way, you wait maybe a couple of hours, you see a clinician, and you walk out no further ahead. You do not know what is wrong with your child. You may not have a clear idea of what to do next. Should you come back? Should you wait? Is this going to get better? People are in the dark. And that's an example of a low quality health system. I want to share with you that it's not just the average child that gets poor care, but when we look at groups of children who are more or less sick, are the more sick children getting a lot of care? Well, here's what the data shows. And each of these bars is a country, and many of them are in this region, not all. What we see is this is the average number of clinical actions that a less sick child receives, so still far short of the total of 14. And here is the additional actions that an extremely sick child receives. What does this tell us? Those people in the room and online who are clinicians, and that's many of you, will know that this is a failure of differential diagnosis. We're not able to sort through the sick from the well. And that's a fundamental problem in the health system if we can't do that. Because of course, many conditions resolve by themselves. Let's be honest, we don't need the health system for every cough and cold, right? But we do need the health system when the child is dehydrated and when the child is not drinking, which is what the red bars are indicating. So let's turn to some examples from South Africa. Some of those were from broadly global in other countries. One of the really important tools in diagnosing health system performance is the care cascade. What is this thing? Well, we start with all the people who need treatment. That's the first bar. And then we follow them through the health system to see, are they getting the key components of care that they need to get better? Each bar tells us what percent got that component. And I'm just sharing with you some data on hypertension care. Hypertension is one of the most straightforward in a way to control chronic conditions. And it is so important, right? It is very much implicated in premature mortality among so many of our patients. We know it leads to many health conditions, including stroke and heart disease. So we really do need to get a hold of hypertension. Primary care is one of the focus areas of in your country. And it is a perfect platform for treating hypertension. And yet what we see is that we have big drops from people who have hypertension to people who are actually diagnosed, who then get on treatment and whose hypertension is controlled. The global gold standard is that 52% of hypertensive patients with hypertension can be controlled by the health system. But many countries are achieving half of that, 20%, 25%, for example. So there is a problem with a competent system. The system over the course of care is not able to treat the patients. Let's talk about another aspect of system competence. This is the issue of family planning. A lot of people have need for family planning, and there are resources in the health system for meeting that need, and yet those two things don't come together. We have a large unmet need for family planning in parts of your country. And you can see this is a map that was done. This is a South African research study just showing how big the gap is across your country. And it's very important to look at these subnational differences, right? Because many good models already exist within the country that can be expanded. And I've learned about several of those excellent models that originated right here in KwaZulu-Natal that then became nationalized. Okay, so let's move now to user experience. Now, hopefully, I hope you're being skeptical where you're sitting, as I always try to be, and question received wisdom. You might say, why do we care so much about user experience? Why? I would give you two reasons. User experience is important because users who feel disrespected, who feel maltreated, won't come back. It won't come back. And you know what? The next health crisis that we have, they might not listen to your health advice, right? Because they do not feel looked after. The second reason is that inherently, people who are sick are more vulnerable. And it is the duty of the health system to extend special respect to people who are vulnerable. And so those two reasons are, I think, very important for measuring respect and user experience. And what we see, again, each dot here is a country. What we see, is this, is it better? Oh, I think I can hear. Okay, great. Again, what we can see is on average across many domains of user experience that about 1 in 3 patients have a really hard time in the health system. They have a really long wait time. They have a really rude provider, or they might have an extremely short visit in which they don't get to talk about what's the problem. So we have issues of user experience, which is an essential part of quality. Altogether, then, maybe it's not surprising that data show that globally, fewer than 1 in 4 people believe that their health system works well as it is today. So let's flip that. What does that mean? 75%, or 3/4 of the population, do not like what they have in front of them today, would like to see a major reform or total overhaul, right? So this is the status of confidence. So how do we improve? Where do we go from here? And Mosa already mentioned that QuEST has the two areas of work: measurement, how do we measure better, but also how do we improve? Well, let me start by saying how we don't improve. We don't improve by going to our old playbook of trying to tell providers what to do at every clinic all of the time. Of course, providers need reminders, they need protocols, and they need standards. But if we rely solely on these tools, we will not achieve a high quality health system. Let me just give you one piece of evidence for this. This is data showing what happens 2 years after a short training on antenatal care or sick child care. 1 week, 2 week trainings are very common, and they're intended to bring the quality level up. And often you get a really big jump in the post training test scores, right? 20 percentage points increase. But 2 years later, we see hardly any impact on the actual performance of care. People don't remember that training. They don't apply it. And so the effect is very short-lived. Furthermore, a very powerful study looked at the ability of checklists and monitoring and reminders and coaching to improve care of pregnant and delivering women in hospitals, or in health centers, I should say, in India, where about 1/3, 40% of women deliver not in the hospital, but in a more of a primary health center. They worked very hard with these providers. Most of them were nurses, and found that after all of that effort, there were 300 clinics randomized into this very high quality study. Literally no lives were saved after that coaching and mentoring program. Why? Well, the women who were running into complications that threatened their lives or their newborns' lives, there could be nothing done for them for their emergencies in those clinics. They really needed to be in a very different place to begin with. It wasn't about their effort at that level. It was about changing the level of care for those deliveries. So we're attacking the problem from the wrong angle if we start at the clinic and the provider. We need to step back and look at the system as a whole. And so what did we say in the commission around recommendations for improvement? And these, I remember the room. I literally remember the conference room in Johannesburg where we sat with the improvement group. We sat there and debated and discussed what does the evidence point us toward. And what the evidence points us toward is that high quality health systems can only be built by structural change. Taking a step back and looking at the way we've organized our health system, specifically governing for quality, having a common idea of what is quality across the whole health ministry, across all of the clinics. Everyone can say, what is it we're working toward? It is about good management within the governance. It's about financial management and payment systems. It is about how we manage the health workforce, crucially. Those are all parts of governance. They need to be revised and looked at again to make sure that the system is properly aligned to move in the direction of quality. Second point, modernizing education. This is completely critical. And I'm not talking about those one-week courses now. I am talking about the hard work that is going on in clinical education for doctors and nurses. Why? Because the curricula that we inherited and that you inherited from many of the colonial authorities back in the day were extremely focused on rote memorization and pathology-based diagnosis, instead of taking live patients and being able to problem solve, to think critically, to work with across teams. And I was so delighted really to learn more about some of the reforms that have happened already in South Africa to reform medical curricula. These are not easy things to do. You know this even better than I do. Reforming a medical curriculum, everybody has a stake in that. And yet you were able to make major reforms already to your undergraduate medical curriculum and postgraduate. So modernizing education is absolutely essential to improving health system quality. And so is igniting demand. I would just ask you this question. What service sector have you used lately that has not asked for your opinion? You know, when I flew over here, my flight was delayed by one hour. No, actually more than that. I immediately got multiple apologies from the airline and a survey at the end of those apologies to rate that service. Healthcare is a service. Healthcare is a service. And yet we really don't take the views of our users seriously, I would say, in many countries. We don't even ask. And even when we ask, do we really use them? What do we use them for? When's the last time you made a big change because of user views? So we do need to ignite demand. And if people are not asked, they cannot tell us. And we need to work with communities to even increase their expectations so that they can help push us toward better health systems. So communities are a partner in this travel. And lastly, but definitely not least, we need to rethink our delivery models, our care delivery models, so service delivery redesign. Once again, many of the care models, many of the clinics, many of the approaches to care that you have adopted and have many countries have adopted came out of the epidemiology of 50 years ago, right? You had a major transformation of your health system with the advent of HIV/AIDS, of course, which was a huge shock. And you reformed, you revised, and now you're achieving some of the world's best outcomes for those patients and those babies, right? So you've already redesigned your health system more than once. And I think what we're calling for is, again, a 21st century redesign for the new conditions that are coming forward to the health system, the chronic diseases, the multimorbidity, the mental health problems that are so aggravated by COVID. We see this the world over. So once again, we have to redesign the health system like you've done before, intentionally and with evidence. Let me say a little bit about measurement, because I think many colleagues in the Department of Health spend a lot of their time on this. And what do we need to measure? First, maybe radical notion is maybe we don't need to measure as much as we thought. Maybe we need fewer measures, but those measures should be concentrated on what matters most to our populations. What matters most to our populations? We need to be measuring doctors and nurses and supplies, but those are sort of administrative measures, right, that are used for management. But in terms of what we communicate, how we measure our own performance, it is not just staffing. It is what happens in the clinics. So we need to measure health. Health outcomes have to be measured. Vital registration is critical for that, because you do not know your denominator. You don't know who died if we don't know who's born. So that, I know you have made a tremendous amount of progress on this front. Health is important. Outcomes are critically important. Perinatal mortality, stillbirths. I am learning about some of the trends that you've had around some of those important health outcomes. The next area is competent care and systems, and knowing what actually happens in clinic. Are people getting the recommended care? Are they retaining what they get? Patient experience, we already talked about this. Are people treated with respect? How long are they waiting on average? How far was their travel to this clinic? So user experience. And lastly, confidence. Are people willing to give your South African health system a vote of confidence? So I did my own little research on the way here to South Africa. Well, we have other research that I'm going to share with you tomorrow. But for today, let me just talk about exchange I had with a taxi driver who brought me here from the airport. And I like in every country I ever go, I ask the taxi drivers what they think of the health system. And he was a young man. He looked very healthy. So presumably maybe not a great big user of the health system. So he thought a little bit about this. And what he said to me is, well, I think it's actually quite good. I think it's pretty good. And I said, well, how would you know? How do you know? He said, well, our politicians don't leave the country when they need healthcare. Our politicians stay in South Africa when they need healthcare. Okay. And I was just blown away. Why? Because guess what? When we were discussing measurement in the Quality Commission, we were trying to push ourselves to say, what would we do if we only had one indicator or two indicators? And you know what? One indicator we came up with in the commission is the indicators, even in the report. If we're only given money to measure one thing, it is to measure this. Is the health minister willing to deliver in a district hospital, randomly chosen? If she is willing to do that, we have a high quality health system. So really his comment in the taxi was very similar. Are they willing to get care in this health system? So confidence, it matters. Let me say briefly about QuEST. So all of this has given rise to QuEST. QuEST was formed as an international research partnership that is intended to pick up, to try to answer, to give more evidence around the issues that we thought were central to high quality health systems, but yet under-researched. So we brought together a group of colleagues to do this one thing together, which is to build the evidence base to support a transformation to high quality health systems by improving measurement, by testing solutions, and by creating knowledge that can be generalized, not just for this one subdistrict, but for KwaZulu-Natal, for South Africa, and maybe for neighboring countries that could be generalized. And that we do together in partnership, not just across researchers, but also with ministries of health in all the countries that we work. So that is the goal of QuEST, and this is our website. You're very welcome to visit. Here is all the folks involved in QuEST. It's a gigantic international family. And we are so proud to have South Africa as a key and really founding member of QuEST. We have a center in the US, in Switzerland, in Ethiopia, India, Kenya, and then several linked centers in Latin America. You can see this is a global set of challenges we're answering, right? The challenges will differ setting by setting, but the approach we think is quite similar. And we are not taking advantage of some of those similarities today. Around the big circle are members of the QuEST network who are doing perhaps one study with us instead of all of the work together. We also have a training agenda. We think skill building and understanding the issues of health system quality is very important so that we have the same vocabulary and we can all benefit from the same cutting edge knowledge. And to this end, we have several courses that we're either already providing or are going to be provided soon, including soon an online self-guided course and a 5-day course for researchers, which a version of this is being provided already every fall at Harvard. But we hope to also bring that out of Boston. And then a 2-day policy workshop for officials and policymakers and researchers. And guess what? We're going to be piloting that with you tomorrow and the next day. So this is the first country we are doing this 2-day policy workshop. The research agenda of QuEST specifically is to develop innovations in measurement and improvement. What are the innovations in measurement? We have something called the People's Voice Survey, nationally representative survey of people's perception of system performance. What do the people think of your health system's performance? Next, the e-cohorts. We know that a lot of the benefit of healthcare does not come from one visit. You need multiple touch points. You know this better than anyone because HIV is a lifelong disease, and this has been such a challenge for the health system. Already you know this. And so I think what we're learning with the e-cohorts is how do we diagnose care deficits, health system gaps by following people over the course of their care to identify where things failed. Next area is the health system resilience during COVID. Professor Mosa already alluded to this multi-country study where South Africa was a major contributor to understand what happened to health systems during COVID. Did they look after other conditions as well? Because that's a high quality health system. It has to keep doing its day job as well as responding to the shock. And then very importantly, on the improvement side, we are piloting new approaches to understand how we can nudge health systems productively toward better care models, updated care models, different ways of organizing our care to improve the health of our populations. service delivery redesign is about reorganizing the care that we give today so that we really maximize every patient contact to improve outcomes. Very briefly, these are some of the areas we are asking about in the People's Voice Survey. We see the People's Voice Survey as a complement to the other performance measures you're already using. This isn't meant to substitute for the important measurement you're doing on mortality, for example, or access to care. We are taking now the voice of the population and saying, how do the population receive this? How does the population receive this? The People's Voice Survey is something that should be done every year, really, in every country that cares about accountability. Why? Because, you know, we just did a People's Voice Survey. Those of you who are staying with us for the next 2 days, you're going to hear some early results for South Africa from the People's Voice Survey. But remember, that was done right after COVID. The question I think many policymakers have is, what is the people's perception next year? How is it evolving? How is the confidence being rebuilt? These are important questions that are vital. Why? Because people are users of the health system. We need to know that they're confident, but also because they're paying taxes. They're paying into the health system. Oh, wrong way. We have data not just from South Africa, but from a number of countries around the world. And we're very excited that the first wave of data from 10 countries is already available and we're analyzing. E-cohorts, we already discussed about measuring weak points in the health system so that when we think about redesign, for example, we know where to start. Where are the problems? Maybe in your country, you're doing extremely well on care continuity for HIV. But actually, people with hypertension are falling off after the first medication is dispensed, right? We need to know that so we can address that weak point by taking a systems approach. And maternal newborn health continues to be a challenge in your country. Your rates of newborn mortality, while they have fallen dramatically, of course, over the last decades, are still higher than you want them to be for the Sustainable Development Goals, right? And they're certainly higher than your investment in the health system should be achieving. Service delivery redesign, such an important area. Every system is evolving, and I already mentioned South Africa has given the world several excellent models of health system change, health system redesign that have happened organically and have also happened intentionally. We want to continue to see the system as a living organism and help push it, nudge it in the direction of better performance. So reorganization of the care model is what's needed. What do we mean by that? Who's receiving care? Where are they receiving care? And what is the care that they're getting? Who is providing care? Professor Mosa has been trying to persuade me that community health workers can do a great deal if they are being properly supported, right? If they're being properly trained and rewarded, and their work is targeted to where the community really needs them, and they are not overburdened. All those things have to be there, right? But they can be a huge ally. And the goal here, I just want to emphasize, the health system's goal should not be to measure contacts with healthcare. It should be to measure outcomes of that healthcare. Simply saying people come to clinic is not good enough if the clinic is providing 30% of the expected tasks. So always focus on outcomes, user experience, care competence, and of course, the very vital issue of confidence and the respect that population feels from the health system, because they are complementary to the clinical care in producing a healthy and a confident, a trusting population. So thank you so much. I'm really delighted. And I will just leave you with a photo of our QuEST family in our first in-person meeting post-COVID in Argentina. Thank you.
Thank you so much, Margaret, for that input. Really appreciate it. I hope that colleagues, you now have a bit of a sense of how we are disruptively thinking about health systems going forward. And when I was in medical school and when I left medical school, and for many years of practice, I always thought that my main job as a doctor is to save lives. And that's what society told me. Until some years ago, maybe about 5 or 6 years ago, I attended a commission on aging, healthy longevity. And one of the things that stood out for me from that discussion was the issue of dignity. And I walked away from that experience thinking, I was never really taught how to restore dignity, how to maintain dignity, how to uphold dignity. when I see patients. I was taught how to save a life. Even then, I was not particularly good at it. Some people, as Margaret said, will survive anyway. And some people, there's really not much you can do in a system that we may call dysfunctional to actually save them. But that was my quest. My quest was to save lives. And now I realize, and when I talk to students, that you also have to learn how to maintain someone's dignity from the beginning, how to protect it, how to preserve it, how to restore it where it's been eroded, how to uphold it. And all of those things require for us to do things differently, to think differently, and to approach things differently. So it's so exciting for me to actually think that when I now think of health systems and a high quality health system, I have to ask myself, do people actually see value in what we offer? Do they trust us in what we offer? This is the question I have to ask myself every time. And you can do it at a broader scale. You can do it at a local scale. You can do it even at an individual level, to make it our mission to ensure that people can trust what we offer. And that building of trust is something that we cannot necessarily do once off. We have to do continually. So thank you so much for that. I want to take this opportunity to invite our head of department in KwaZulu-Natal, Dr. Sandile Chabalala, to say a few words. Doc, are you online?
Good afternoon, Prof. Good afternoon to the panelists, and good afternoon to all the attendees. I won't be long, Prof. And I'm in a place that does not allow me to really show my picture, so I will not open my camera. I'm just dealing with these strikes, so apologies for that. I was listening to the presentation that just finished now, and I think I would like to say that I'm looking forward to us learning more about how we should improve the efficiency and effectiveness of how we treat and manage our facilities, but our clients more, our patients. I think if we deal with it at this level, such that even the curricula at the universities, not only UKZN, but all universities, appreciate that when we treat clients, we should treat the client, not the illness in the client, such that how we communicate with them makes them feel comfortable. And as such, the question that was asked of what is the experience of the client does not even emanate. I think if we start in that direction and teach our young that some of the important virtues is the respect for the very clients that we are treating, and therefore be able to say when a client comes, even if we think it's an illiterate person, they are not objects that we are going to use to enjoy the science that we are going through, but they have some emotion. More importantly, they have relationships that may be dependent on them. And as such, we should treat them thinking we are treating one person, but we are having an impact on a broader society by whatever outcome of that treatment. Prof, allow me to just say those few words, but ask that a partnership of this nature not be a partnership with a session of this nature, but be an ongoing partnership where our care for the clients is reviewed again and again, such that our efficiency and our spend on health is really reviewed and reduced where possible. But let's continue to all learn. I think I would just want to stop at that, Prof. Thank you.
Thank you so much, Doc. That's really much appreciated. And as you know, Dr. Chabalala, we are committed to continuing to build this relationship. We are committed to building this agenda. And I hope that you are noting that even the collaborations that we are forming with our partners from across the world to also learn from them in terms of what is it that they're doing and to share experiences is also part of our commitment and contribution to this effort. And at the end of the day, we are going to measure our success in terms of how it translates here in KwaZulu-Natal, first and foremost, but also how it translates nationally as well, and hopefully also with our neighbors. Thank you so much, Doc, much appreciated, and thank you for your presence. And once again, we wish you well in the efforts you're making to contain the crisis that we are experiencing in the country. Colleagues, allow me to then invite Dr. Anban Pillay, who is the DDG for Health at National. Doc, if you are available, can you please open your mic and engage members who are present here in the room and virtually as well? You're most welcome.
Thank you, Prof. Moshabela, and good afternoon, Professor Crook and all the colleagues seated there and online as well. Apologies that I was not able to attend this exciting session and week. I think the public sector strike has also consumed much of our time here. But I hope that this is one of many, and so I'll have an opportunity to engage. As Prof. Moshabela was saying, I had no idea that QuEST was an initiative that had already started. I had called him, given that he was now represented on the MRC and a number of other bodies doing research, that I do believe the missing piece in the health system is connecting universities to the health system or the delivery platform as such, to an extent that would allow us to work more effectively and efficiently in delivering healthcare services. And he then informed me about QuEST and what was going to go on in QuEST, and so it was very exciting and timely that I called him about this. So I think this is a really exciting initiative, and from our side, I think we would be very keen to participate in the initiative, because I think in addition to KwaZulu-Natal, I think the other provinces will certainly also benefit from the work that you're doing, and I think it's an example of what could be done across the country. Professor Crook certainly stimulated my thinking around her questions and her responses. So I just want to start off by mapping a little bit about our health system that she may or may not be aware of. But South Africa's got a two-tier health system. I think it's important to bear that in mind. The reason I say that is when she spoke to the taxi driver, it may be good to have asked him what he thought of the two health systems rather than just the health system. So we have a public health system which is made up of about 85% of the population accessing it, and a private health system which is largely, I would argue, based on those that can well afford to access care. There is a high disease burden that has to be managed in the public system relative to the private system. So you would find that the ratio of health professionals to patients in the public system is very low relative to what you'd find on the private sector side. So consequently, if you looked at quality, which I think is the main focus of today, you would find longer waiting times, certainly in the public system. You'd find lower levels of cleanliness, for example. You would find higher workloads. And as a result of that, you would find probably staff attitudes not the same as they would be in the private system. And you would have probably lower levels of communication with patients about what's wrong with them. And so the point I'm making, I think, is that the quality of care is intimately linked to financing and the way services are delivered. So we've proposed a national health insurance system that I think we would probably want to talk about at some point, probably not today, given that the extent to which we'd probably need to discuss that. I think it's important to also appreciate that the cost of healthcare in South Africa is significantly different between the public and the private system. The private system probably spends around 7 times more than the public system in terms of delivering the same type of care relative to the public system. Prof. Crook was talking a lot about, the user expectation. I think when we talk about quality and the user expectation, it's also important to reference that against the health professional's expectation of what he or she thinks he wants to achieve out of this. And I think that's where probably the disconnect comes in. And at various levels. So if you're a patient accessing care in the public system in South Africa, you don't have many options. So it's not as if you could say, I'm not coming to your clinic anymore. I'm going to go to the clinic that's not too far away, that's run by a private provider, because the quality in this clinic is not good. And that unfortunately has created this structural problem in the system and affected quality, because at the end of the day, if the providers of healthcare are aware that there are limited options available to those that are using the public system, then the delivery of quality of care does not become the primary objective of those that are delivering care. And here again, I bring in the national health insurance, because that's probably the key to creating competition and options for patients, but at the same time, making providers of healthcare aware that if they fail to deliver the quality that patients are looking for, that patients will go elsewhere. When we were looking at that quality of care many years ago and asked the question, so what would patients be expecting from us? And there's been a number of surveys that have been done around what's the expectation, and I can probably summarize them in 4 or 5 key areas. One is people wanting shorter waiting times. They were looking at issues of cleanliness of the health facility and the infrastructure, the attitude that staff have, and whether they get communicated to in a manner that helps them understand what's wrong with them, and receiving what I would best describe as symptomatic relief. And here's where the disconnect comes in. If you then went to the health professionals and asked them, so what do you consider to be good quality healthcare? Issues of waiting time, cleanliness, attitudes, etc. are not high up on their list. On their list are questions such as, do I have the necessary equipment to be able to do the diagnostics and surgical interventions that I need to embark on? Are the medicines available that I would want to prescribe for this particular condition? And have the clinical outcomes been achieved that I was hoping for? And those are largely the disconnect between the public and the private system. In fact, we introduced a health market inquiry to understand how we can better reform the private health system. And one of the key recommendations in that inquiry was that South Africa needs to measure health outcomes, because until you measure it and publish it and share it with patients, you will not get users to move towards a system that is based on these types of clinical outcomes. Legally, we've already actually entrenched this in law, because the Office of Health Standards Compliance is required to collect this type of clinical outcome information. But guess what? The private health system that I spoke about, which is the one that supposedly should have the high quality healthcare, is not very keen on providing you with clinical outcome data. And we had a very good experience of this during COVID. During COVID, I tried to collate information about the number of deaths in the public and the private health system. Actually, in the public system, it's usual to collect mortality data and submit that to head office, such as Dr. Shabalala's offices in the province. But on the private sector side, there's very little attention to mortality or why mortality occurred. So while they may focus a lot on the hotel quality services, very little on the clinical quality side. And so there needs to be that balance, and I think users need to also appreciate this. I think a lot was said about measurement. And one of the issues we understand by measurement is very difficult to implement in the absence of a relationship to reimbursement. So in the private sector, you get very good measurement data. And the only reason you do is simply because providers will not get paid unless they're able to supply the data. So they are obliged to collect it. They're obliged to code, etc. In the public health system, the opposite occurs, where reimbursement is not linked to the type of service and the quality of service you've provided. So nobody collects anything. And so clearly, in order for us to move towards a system of measurement and looking at the quality, it has to have a relationship to the way reimbursement happens. I think the Medical Research Council recently published some work around clinical record keeping. And this is something I think linked to universities. When they looked at the record keeping, particularly on patients that are demised, it was very difficult for them to work out what was wrong with the patient at the point of admission, how did the patient progress, and what actually led to the death of the patient, just looking at the clinical records. Yet the very same clinician, when he or she is being assessed in his final year of medical school, will have excellent clinical notes because that's the basis on which he or she is assessed, right? But behavior within the health system discourages them from keeping that level of clinical detail. And so we now have a situation where we have to do training in order to remind them about what they did in their 6th year, which is a very interesting a dilemma that we currently face, but something we need to deal with. In trying to measure quality in the health system, we've introduced a body referred to as the Office of Health Standards Compliance. And this body has developed a number of indicators that should give us a sense about the quality of health services being delivered. Having said that, I probably will be the first to say that the relationship between the indicators and what actually happens in the health facility is a disconnect. So in other words, there are SOPs and guidelines about what should happen. But whether that actually happens is a different matter. And I think that's where we need to bridge the gap between what's expected and what actually happens. And how do we get that behavior change to occur? And what are the incentives to nudge people in that direction? Which brings me to the point about why I called Prof. Mochabela in the first place, was to ask the question, well, could universities work with us in the health system to try and understand how do we deal with these policy issues and what I would call soft implementation issues, so that when we implement something, it actually has traction. If I can just share with you some of our experiences about what we assumed would happen in the health system and what actually happened. About a decade ago, we were issuing patients who were HIV positive with 3 drugs. So 3 large containers of medicines that they had to take home on a monthly basis. And it caused a burden on them in terms of when they needed to take them, etc. And we assumed if we were able to innovate a single pill taken once a day that would avoid all of these challenges, that people would be lining up across the country wanting to take this medication. Guess what? That didn't happen. Patients said, these 3 tablets are probably more than the single tablet that you say you have, so I'll stick with the 3 tablets. And so we had a lot of work to do in trying to explain, not just to patients, but clinicians as well, who said, well, the patient is fine with these multiple tablets, so why do you want to actually change them? What's the purpose of the innovation? So I do think there's a lot of work to be done around evidence-based policy making. And if you look at, for example, the data that's published and the questions that we ask in terms of the health system, you'll often find that there's no evidence for what needs to be done. And so the question then arises is, so what do you do in that context? And our approach has been, well, let's do a pilot. Let's try and understand whether what we're trying to do is measurable, whether the outcomes will be in line with what we're expecting. And then how do we then scale it? And I think that's where this close relationship with an academic institution becomes so critical in terms of delivery of healthcare. So, I mean, those are my initial thoughts. I would have loved to have been with you for the whole week, because there are lots of other issues I would probably want to pick up from your discussions, but I'm hoping that this will be one of many, and we can engage on those issues that I raised with Prof. Moshabela when I called him. Thank you.
Notes taking and records. There's a lot of work to be done. I do think that it's really important to understand the big picture and to also understand the national direction, policy direction, as you outlined the national challenges that you face, but also really the things that are also coming that are going to change the system. They're going to put pressure. I mean, there's no doubt that the national health insurance is going to put pressure on the system. It's going to force the system to change, and many other things. It's not just things like COVID. In KZN, we're also talking about how things like floods are also influencing how people seek care and how health systems are organized. But I do think that these other things are also very important in terms of UHC and health insurance. Margaret, I hope that you realize that Dr. Pile is well trained in health economics. If I'm not mistaken, he was trained in London School of Economics. That's why you can see also the concerns around financial protection, which is really an important part of governance, and the things that people who are in governance are very much concerned about. So I do think that for those of us who are on the ground also, we're very much concerned about the soft things that we're talking about, the soft implementation things, which are not really soft there. I see them as very complex and very hard. So I'm hoping that we can take these things forward. There is also Dr. Sfiso Mjali in the room who, like Zama, we've been working with to try and make sure that we can strengthen the relationship between the university and the National Department of Health, but also more broadly government. You know, we've been talking a lot about how many of the social determinants of health are also influencing and affecting people's behavior. They can't hear me? What happened?
Can someone assist us?
Can you hear? Can they hear me now? On Zoom?
I can hear you.
You can hear me. Oh, they can hear me. Yeah, you can hear me. Thank you very much. I hope you can still hear me. I think what I was getting at is the fact that that's kind of scary. We are developing multiple channels of strengthening the relationship between the university and government. And when it comes to government, our primary relationship, of course, is with the Ministry of Health, because we work in the health sector, we work in public health, work with health systems. But because of the problem of social determinants of health and the broader drivers of ill health in the communities, in the households, issues of inequity, we have had to think about how to tap into other opportunities that are within government. So the notions of a multi-sectoral approach is something that is appealing to us for those unique situations where we may need other partners who are outside of the Ministry of Health to assist and step in and help us as well, which is also why we have formed, we are increasingly working on forming this relationship with the Office of the Premier, because the Office of the Premier essentially oversees the relationships with government across the board. And what Dr. Swisam Jale has been also doing is to assist us in terms of building a relationship with the Department of COGTA, Cooperative Governance as well, because they are very much interested in working with universities to draw on the evidence and the expertise that sit in these institutions in order to strengthen service delivery. And for me, this is something that is very exciting for me, because in the past, you would almost fight hard to make sure that evidence is made available to the policymaker. But right now, the situation is very different. The policymakers are actually looking for evidence in order to guide their decisions. Part of the issue is the fact that there's not a lot of money lying around, and we need to get a big bang for our buck for everything that we do. But also, we need to cooperate a lot more. We need integrated approaches. One of the things that Margaret alluded to is the fact that we succeeded in KwaZulu-Natal in terms of dealing with HIV, for example. But what happened to TB? We lagged behind tremendously. Lagged behind. And we are still way behind even now. We're making progress now, but we are having to pick up the pieces. We succeeded in KwaZulu-Natal in bringing down, for example, maternal mortality. But what happened when COVID hit? Maternal mortality jumped. So the moment there's a shock to the system, already you lose the gains that you have had. And our system is not very agile, and it doesn't adapt very quickly to such things. Now, we want to make sure that the harm that comes from ill health, from mortality and morbidity, that can be avoided, we do as much as we can to avoid. We want to maximize our gains in terms of health outcomes. At the end of the day, people have to feel safe when they have a health system and they have a health service in this province and in the country. And so, indeed, Dr. Pillay, we are going to make this a series of engagements because at every turn, there will be new information coming out that we need to discuss. There will be new challenges to the health system that are going to demand for the health system to adapt. Those discussions need to happen in terms of how the health system is going to adapt and how to prevent or minimize unintended consequences and collateral damage. Sometimes we cause harm, those of us who are having to make decisions and inform decisions unintentionally, because we're doing something that we believe is good, but because of our own blind spots, we end up resulting with a bit of a problem on the side that we did not anticipate, which is also why a collective approach is so important. It can't just be us sitting in the university or in this room deciding as researchers. And it also just can't be government officials deciding on their own. It is when we come together that we are able to look at the same thing from different angles and begin to come up with solutions that minimize the blind spots and also hopefully minimize unintended harm. First, do no harm. So I'm hoping that with this platform that we are creating for engagement on health systems transformation and the contribution that we can make from the academic side in terms of providing the evidence that is needed, to collecting the evidence, to synthesizing the evidence, analyzing the data in order to help inform these decisions, this will be an important contribution. One of the things we were discussing just today is that actually, as health systems adapt, we are realizing that even the way we measure needs to adapt. You can't measure a system that is changing shape and form with old tools and ways of measurement. You need to adapt, which is also putting pressure on us to monitor and understand these adaptations that are taking place so that we can constantly improve our measurement, so that we can inform decisions. At the point that was made by Dr. Pile about how there's a disconnect between the indicators that the Office of Health Standards and Compliance have to the reality on the ground. That disconnect is something that we need to help resolve. And we can only resolve it by also understanding better what is happening. So I want to take a few minutes to just open the floor to invite colleagues to make any inputs, comments, reflections, and please feel free to comment. Whatever you are sitting there thinking about, reflections that you may have, we would like to hear them before we close. Do you have a mic for Dr. Bengu? Yeah, he'll give you a mic right behind you.
Good afternoon to everyone.
Afternoon.
Thank you very much for the invitation. You have right in front of us my mentor from the commission. When sometimes I want to say something, he just is there always to say it very eloquently. So I'm very pleased to be here. One thing that there's so much that has been said, obviously, one would have expected that coming from you, having been known a part of you as a member of the commission. And some of this I want to emphasize from the point of view that seeks to make us understand how complex the work that we're doing is. And so that one of the points that I wanted to raise is to do with the competition out there. The time has passed whereby we knew that we kind of health were the only ones in the field. Today we have alternative health. We've got traditional healers. We've got all sorts of people or professionals that our woke society can refer to. And so the other point was that we're dealing with a woke society. People, that's a term that's used these days, especially young people. People who know what their rights and they know what they want. And they have been, unfortunately, disappointed and hurt by the health system in the past. I mean, in one of our sessions with the community last week, they were actually having a short drama on how the clerks in the clinics, clerks in the clinics treat them. It was like a joke. And so I want to invite you to that forum. It's ready and whatever. The other point that I liked was modernizing education. I was a bit uncomfortable, not because it's wrong, but because I didn't understand what we mean. Are we wanting to go back, understanding the Afrocentric approach, or we want to move ahead, working with this Eurocentric approach, which may not work? So modernizing for me was something that I could not understand what it meant. And of course, we're talking, you've mentioned, say, the issue of inequality. And the other thing was the World Health Organization. I'm in old school. And when I look at the definition of World Health Organization, I don't know whether it has changed. It says it's not the absence of disease, it's mental, emotional, and spiritual well-being. And I think to some extent we've missed those other aspects. I remember at some point I was always almost punished for saying we don't seem to be Department of Health, but of disease, because we tend to focus on disease. Now, I was pleased when I think the HOD, Dr. Shabalala, mentioned the fact that we're dealing with the person, not the disease. And the issue of social determinants, that's my specialty, that's my passion. And that patient experience is important, behavior change is important, the issue of dignity and everything. And I was looking at just how does the current training system, how does it prepare a health professional so that they have this? And so I'm here to offer myself as a person who brings that. Having been lucky, I'm not looking for a job, but I really, but I'm lucky to have studied just everything, from nutrition to poverty to health policy. I mean, what more do you want? And then, yeah, so I think that's why you invited me. But
you are applying for a job, clearly.
But it basically means we're going to cut off all the years of experiences. In fact, I was sharing with Dr. Mchadi, who was a colleague of ours, in that so many years I found the institutions are not open to just the unusual. I mean, I remember how many years that one has been talking, I don't know, about when we're talking about the importance of bringing the social aspect in the training, because in 1 year, whatever, you can't capture all these things. And so again, you've got a professor here. I love laughing, that's what health is about. And from the perspective of the patient, just getting yourself in the shoes and how to do that. And when you understand the complexities of those people, how far they come from, really to be unfair to expect you to be all that, but it's expected. But I just say, and the issue of community health workers, I think those are food soldiers, and I'm really not sure if we are using them as we should. And those are the other people that the allies that we can use. I think without wasting time, the issue that you should be trusted. I mean, when do you build trust? How long does it trust? We know in our relationship, could be married for so long, but we still don't trust each other. So how do we get, getting in from a process now. So how do you build trust with people you meet once in a while who already have those things? So, so I think it's not something that we can build once off. It's something that we need to continuously do. And as people coming from the community, we're really wanting to partner with you, appreciating the kind of hard work that we're involved in. With those words, thank you very much for inviting me. Thank you.
Thank you so much, Dr. Bibi. Let me not say anymore. The perspective of the community, the perspective of the people is something that we are also learning. And we realize that in order to achieve a system, a health system that is able to deliver quality care and quality service, we really do need to take that perspective into account. Margaret mentioned the People's Voice survey. This is a survey that was designed from scratch. And when we designed it, we looked around to see if there are other things that try to measure that perspective. And we didn't find much, and especially at a scale that we wanted to measure. And also measure with the level of accuracy that we are looking for. It's not something that is easy to do, which is why we went through a lot of effort to try and design these tools, test them, and try and pilot them in different places to see if they actually work, until we were left with something that we thought was reasonable. And because we were also doing this during COVID also, and also because we want to be able to reach so many people in a short space of time, we don't want it to be burdensome. This is something that we had to design for telephone surveys. And if you're going to interview people for more than 20 minutes, they're going to lose interest. So you have to keep it focused as well. But fortunately, even in South Africa, the People's Voice survey is a survey that was done nationally. It's not just done in KwaZulu-Natal. So it will offer insights, and hopefully in the future, we'll continue to do it that way as well. And we will be able to compare with other countries where we have used similar surveys, so that we can then also benchmark with our peers, benchmark with our colleagues elsewhere to see what is happening. And I'm hoping that, you know, as we take this work forward and we start to engage, we can also improve these tools with your feedback. And also, I do think that what you're also saying, Dr. Bibi, is that we need to make sure that we can package this information so that we can have conversations about the data and the evidence at community level. In those platforms where drama is taking place, we need to be able to discuss these findings as well. So I want to thank you for your inputs and your offer to make yourself available, and we will take advantage of that. Dr. Bibi always, I call her the thermometer in the room. When she is in the room, you get a sense of whether the discussion is going in the right direction or not. The reaction you're getting today, the discussion is going in the right direction. If it was not, you will know. And this is based on many occasions of sharing very hot debates at the Premier's office as well. So any other thoughts, colleagues, reflections? Anyone online want to say a few words? Margaret, would you like to reflect on some of the inputs that have been provided? We can give you a mic. You don't have to get up. Yeah, go ahead.
Well, first, let me just thank you for the engagement. Just the comments from online and in the room really highlight to me the incredible level of caring about how the health system is doing. And I have to say that, you know, one thing that we emphasized in the commission was that fundamentally, high-quality health systems are a political decision. They start really with the caring at the level of those people that the population elected to represent them, to look after their needs. We also know that when populations experience good or bad healthcare, they form opinions about that political system and about that leadership. We know experiences in healthcare and education, and of course in security and other areas, are fundamental to people's appreciation, understanding of the political system and support. So it's always, to me, incredibly powerful to hear the level of caring in the voice of policymakers. And today, I think the comments that we've had from colleagues at the provincial level, also at the national level, really clearly demonstrate the level of caring. Yeah, that people take this extremely seriously. So to me, that's my first reflection today. I think that just briefly to say that I really appreciate the comments again from Dr. Pillay and others about the need to balance priorities and the need to protect the economy and protect the pocketbooks of families. And I think that's absolutely crucial. It's not the case, although we are health people first. I'm also a doctor. That was my first degree. You know, we care a lot about health. We think about it every day, but people think about many things. And I think we just heard this from the colleague right now. It's not the only thing that matters. Health is a means to a good life, and a life that you spend with your family, living in supportive communities, achieving your aspirations and dreams. We have to remember that it is good in itself, but also a means to other things. And I think as health professionals, we want to keep that totality in mind at all times. So I think the challenge before us is, how do we balance the budget, providing this kind of respectful, thoughtful care, but also critically care that does prevent mortality when it could prevent mortality. As Musa said, when we can save lives, we ought to save lives, and we should be judged on that, right? And let's engage the rest of the social systems, the employment system, the education system, and others to also help fill in some of those needs the population has, the emotional, the social, the economic needs. We're not the only player in town. This is what you're reminding us, Musa. So how to give the care, the focused care and respect that people are expecting from us. That's job number one. How do we afford that? Job number two, and I've heard a lot about national health insurance. I am quite keen, Dr. Pillay, to hear how you will use strategic purchasing or other opportunities to buy that quality, because we know what a challenge it's been in other countries that have adopted national health insurance. Sounds wonderful on paper and really tough to do in practice. But I agree with you, completely agree with you, that giving people more choices and the ability to shift is part of it, because that is one signal that providers get about their performance. Not the only signal, but an important signal. So completely agree on the importance of that. And it's another way to respect the patient, right? It's another way to respect the community, to say, this is not the only place that is there for you. We have alternatives. And as you rightly said, people know and today seek alternatives, some of which may be good ones and some of which may simply be, a retreat from the system and not really supporting the health achievement, right, that we want. So I'm just really appreciative of the depth of thought and once again, the caring that I heard in the comments today. We couldn't be more proud to work with the University of KwaZulu-Natal, with Professor Moshe Bell and his whole team, whom we're meeting, many of whom we're meeting for the first time in person, which itself is a great privilege and pleasure. And again, thank you for your hospitality in this beautiful place and in this incredibly engaging and caring intellectual community.
Thank you very much, Margaret. So for me, I want to say that we've had very rich experiences over the years from the time when we've been practicing medicine and learned very harsh lessons as well. And one thing that really opened my eyes in my career was studying care pathways, studying the pathways where from the time when a person gets ill and they go through their illness experience, they go through the healthcare system and navigating it, to a point where when we were training medical students that were coming to our hospitals, we will basically get them to follow a patient. If you want to experience a person's experience or understand how the health system operates, when the patient walks in, either through the gate or when they leave their home, walk with them. So we would send them to do home visits. And for patients that needed to go to the hospital, we'll get them to travel that journey with the patients. If a patient gets chronic medication, we'll say on the day the patient is coming to visit, we want you to walk with that patient, get into the taxi with that patient, go through security at the gate. Just going through security can be quite a job. And then also standing in the queue, getting a file and so forth. All of these things, just experience them. And so it's these things that for us, they've really opened our eyes to say that we need to stop thinking of healthcare service delivery purely from the supply side. It's so easy for us to think of the building blocks, as Margaret was saying, foundations, the supply side things that we need to do and tick the boxes off. But we really need to start looking at the world through the eyes of the patients, through the eyes of the people. We have to understand their voices, even if they use lay language and they're not speaking to the technical things that we care about. It'll be difficult to make sense of those technical things if we are not necessarily understanding their voices. So for me, this has been really insightful. And that's why for most of what we are trying to do is to really try as much as possible the extent to which we can to bring those voices of patients into the redesign and the reorganizing of healthcare, so that the voices of the people do not become a blind spot for us. And we have to do this in different ways. And ultimately, when we do get to the redesign point, we need to make sure that we do this together. We need a core design approach. It's not something that can be done by one person or another. We need a core design approach. In as much as this is hard and this is difficult, it's sort of easy to just sit in the room and make your own decisions. But ultimately, the benefit that we want to see in terms of health outcomes, in terms of economic benefit and other outcomes that we're interested in, and the positive user experiences that we're looking for, the confidence in the system, the competencies that we want to see. These things, we cannot be able to achieve them if we're just thinking unilaterally. We need to think together. And I'm looking forward to the time when we are very comfortable to also sit with patients in the room and discuss with them, with ordinary community members, and plan health systems with them, the redesign of health systems with them. In as much as that may not be the norm today, but this is the direction that we need to go towards. I know that when something has not been measured in healthcare, it has not been done. That's what we say. So I accept that we need to really measure, but just also hearing the stories can also be really powerful. So we need to also listen to those stories. I'm hoping that with this effort that we are doing, the effort to bring an awareness to this work that we have started a while ago, and we need to continue with, of transforming health systems, transforming medical education, health education, transforming governance of health systems, transforming the way we engage with communities and the demand side for services. This work, as we continue with it, I am really hoping that we can do this in a way that also carries the same values that, you know, people are demanding of us, and that we also demand of people who have to provide a service to us anywhere where we go for services. I want to move towards closing this session. But before I do, I want to check if Mr. Ngubane is online or Mr. Mdebele is online. I need someone to help us close by giving a little bit of a reflection for closing purposes. And you can let us know if you are. And I also want to let you know that this is a commitment that we are making to take this work forward. This is the commitment that we are making to take this work forward, starting with the work that we will be doing tomorrow, of piloting a policy workshop, and we will be learning together as we move forward, but also engaging a lot more. I believe Mr. Mdebele is online, and Mr. Mdebele, I would like to invite you to say a few words, and if I may trouble you to also share a little bit on the primary healthcare transformation committee that you chair with many members of the provincial department, as well as district directors and other officials and members of the university. And in so doing, I will also ask you to close the session for us. I would like to hand over to you. I hope you can hear us.
Good afternoon, Prof. Good afternoon, all the attendees of this beautiful workshop. I'm sorry, I'm driving. In case you don't hear me, please indicate that you are not hearing me.
We can hear you.
I followed all the discussions that were provided here. And really, I want to firstly appreciate Prof. Moshabela for the standing work that he's doing, especially in calling for this workshop. And from our side, he is one of, he's the person that is steering the ship. So just briefly, the topic that is being spoken about, as a province with UKZN, we started some engagement trying to figure out how do we then get the recipient of service to have the voice on whatever we are doing as a health care sector. And then from the department point of view, we therefore approach Prof. Moshabela to say, hey, we are good in providing the clinical care, but we are not good in actually measuring what we are doing. So we will therefore like to partner with you so that you can assist us in putting up the measurement. And willingly, Prof was excited, and then we started to bond as early as 2018. So the high quality care, we really believe as a department that is the only way to go. However, to reach where we are going to go, it will be a difficult journey because most of us, we are not acquainted in engaging, for an example, our community in engaging the patient. The way that clinicians have been trained, it doesn't meet the requirement of engagement. For an example, if you go to the consulting room and observe how the patient, the doctor, the nurse are sitting, you will find that by doing that, the sitting arrangement on its own is saying to the patient, you are inferior, you cannot tell us anything, we know best, you must hear from us. So if we have to transform the whole setup, it will require that we actually influence a lot of people to actually join us into this journey. So we have started a PhD transformation committee with the university, trying to actually start the healthcare services from a household level, community, with the aim of engaging community, with the aim of empowering the community to actually have a voice in the healthcare system, to actually empower the community to tell us now we are not doing what we are supposed to be doing, and also empower the actual patients to actually know even better than a doctor, I'm on this medication, I'm taking it like this is the effect of the medication, and also put more effort on the preventive and promotive strategies, because that's where we also find that we are linking. So we really appreciate this launch of QueST today, and then we're looking forward for the next 2 days of the policies training, so that we can also gather or gain more skill. So I really appreciate all the attendees, those that were able to attend physically, those that have been able to attend virtually, and the doors are open to us. We also want to learn. Our main objective is to actually provide the best service that we can provide within the department. So thank you so much, Prof.
Thank you so much, Mr. Mdabele. Colleagues, you have heard it for yourself. We can now engage comfortably on the quest to provide quality health services through a high quality health system with support of high quality evidence. QueST has been launched. Can we give a round of applause? And with that, we may adjourn. Thank you very much. Thank you to those who are also virtual as well. Nisha, come.